I think we should start. So, Happy New Year to everybody. This is the start of the new series of journal clubs, and it has a little bit more international features. For instance, today we have a speaker from Denmark. Lisa Gottlieb will be presenting a paper, and I hope there will be some audience from Denmark too, but I'm not sure whether they will connect.
No, there's a big experiment.
Okay.
So, yeah, and the people are doing that well. So the whole staff is down there with it.
Okay. Well, Lisa, it's wonderful that you're here. For the others, probably you know her, but she did her PhD work in Atelier Rik in Bordeaux, and last year she did a PhD graduation in Amsterdam, and she's now a postdoc in Copenhagen. And she will present a paper on the influence of the autonomic nervous system on cardiac arrhythmias and how to modulate them, which is, I think, very interesting. Lisa, I think you can take the floor, and I invite everybody to interrupt at any moment that things are unclear or that you want to add something. So please, I hope you don't mind, Lisa, that I ask them to interrupt you, but I think you're used to that procedure.
Yeah. Oh, thank you, Ruben. Yes, please interrupt, and no need to raise hands or anything. Just use the microphone. And yes, this is an article I'd like to present to you that was published just a month ago in Heart Rhythm. And I found it very interesting due to that it was very recent. So I think I like that we should discuss what's coming out right now. And then at the same time, this modulation of the autonomic nervous system, and how does it affect the cardiac function and the arrhythmias? So this is a group from Wuhan, and they published several studies using the same myocardial infarction dog as a model. And this is their recent work. And they entitle it Ultrasound-Guided Injection of Botulinum Toxin Type A blocks the cardiac sympathetic ganglion to improve cardiac remodeling in a large animal model of chronic myocardial infarction. So I will first, they state that they have no conflicts of interest. And I have I've taken a bit out from the background, and this is a scheme of the autonomic nervous system, how there are two branches, most of you know, but I also know that Lyric is very, sometimes you are very computer modeling and also very imaging, so perhaps this is more physiological aspect, may be a bit unknown to you, so I will introduce a bit about this autonomic nervous system. And we have two branches. We have this parasympathetic branch and the sympathetic branch. Now we know more that there's an interconnection going on between, but traditionally we say that there are these two branches. And the parasympathetic activity, this is what we call the rest and digest. So this is when we sleep and have our digestion. And then the sympathetic branch is very active when we are stressed, either physiologically or psychologically, in order to have a fight and flight response. And you see out here, you can see my cursor, right?
Yeah.
Yeah. So here we have the spinal cord, and we have some nerves coming out, some preganglion nerves coming out from the C7 to T4, we say, and they go out into these ganglion, stellate ganglions. This is where they had their first synapse. This is a sympathetic nerves. With the parasympathetic nerves, it comes from the medulla oblongata, as we say in Danish, and go directly to the heart through the vagus nerve. Okay, but here the sympathetic nerves, they have this little relay station, and that is where this paper they target the autonomic nervous system instead of going directly close to the heart. There are also other techniques of how you can modulate the autonomic nervous system close to the heart. That's by ganglionated plexi ablation. But here they want to target out here, okay? And the autonomic nervous system is important for our normal cardiac physiology. So have an adapted heart rate and contractility in order to the demands we have. And then, but it also has a role to say in the arrhythmogenesis, especially in the malignant ventricular arrhythmias. Okay, yeah. Then there we have a myocardial infarction. What is that? That is when we have ischemia. We have the schema of the heart here, and you see the coronary arteries perfusing the heart, and we have the coronary arteries delivering this oxygenated blood. And if that occludes somehow, a thrombus or embolus or yeah, in any manner, or just by contraction, I can also a vascular spasm, we can get ischemia. And when it's long enough, we talk about an infarction. Then, and what happens with an infarction? Infarction is very much associated with malignant, I have a typo there, but arrhythmias and a reduced cardiac function. So that can occur both acutely, immediately after the occlusion of the perfusion, but it can also occur on the long term. So what happens, associated with the autonomic nervous system when we have a myocardial infarction? First of all, we have this ischemic area. Then in this area, the efferent activation from the efferent sympathetic nerves going back to the heart or going back to the spinal cord, the ganglionated or the stellate ganglions is interrupted. So you have to think of the whole tissue, not only the myocytes, but also the nerves are affected by this ischemia. And that can cause heterogeneous shortening and refractoriness, both remote from the infarct. And there are a lot of studies looking at this in the border zone and what happens to the nerves close to and so forth. And also it seems that it's not only just the nerves that are gone by the ischemia, but there's also changes in the sensitivity of the nerve. And then on the long term, what happens next? Is now we have this deinnervated infarcted tissue, and with time we have a nerve sprouting, the sympathetic nerves, especially trying to grow out again and reach the region where they were before. And it can cause heterogeneous hyperinnervation and also these functional electrophysiological changes that are not homogeneous. So, and at the same time, we also see structural and functional changes in these ganglion, the stellate ganglion, where the nerves originate. So something happens both at the site of the infarction, but also in the stellate ganglion after an infarction. Okay, so this is the background. So myocardial infarction causes these arrhythmias. So can we do something to the autonomic nervous system to prevent these arrhythmia after a myocardial infarction? And that's what this article asks or proposes a solution to. This is their central illustration that you see here. And they propose that by ultrasound, they use an ultrasound probe here to find the stellate ganglion on the left side. They're both on the left and the right side. The left, Ruben, now I need your expertise in this field as well. But the left seems to have more an impact on the refractoriness, at least on the posterior part of the left ventricle, where the right stellate ganglion has a more impact on the right ventricular refractoriness. And most studies have been done on the left side. So they want to modulate the autonomic nervous system by acting upon this left stellate ganglion. And they do so by an ultrasound, putting an ultrasonic probe to the neck of some dogs. And then they infuse, they give Botox. And what is Botox? Or we can call it they did BTA, botulinum toxin A. It comes from these bacteria that you know. It's a Clostridium botulinum, which is a rod, a gram-negative rod bacteria, and they can block the neurotransmitter to be transported or secreted into the synapse. So we have to remember that these preganglionic fibers are actually, their neurotransmitter is acetylcholine, okay? Even though it's sympathetic. Later on, it goes out and gives adrenaline as noradrenaline as a neurotransmitter. But here it's acetylcholine. But it doesn't matter that much because most of the nerves in the left stellate ganglion are sympathetic nerves. I actually don't know if there's any interconnection with the parasympathetic system. I don't think so. Okay, so they give this drug. And then they say that their objective is, they wanted to investigate whether Botox, can we just call it Botox? I think it'll be easier for everyone perhaps, could sustainably block cardiac sympathetic ganglion and thus play cardioprotective role in a post-myocardial infarction canine model. Er du okay med jer her? Ja. Det er det, Nej, det er helt fint. Okay. Sorry. Yeah, sorry about that. Okay, so this is their objective that they state. And how do they do it? They have 3 groups of dogs. They have their control dogs, and they have their myocardial infarction dogs, and then they have a myocardial infarction dog that they give Botox to into the stellate ganglion. And how do they create their myocardial infarction? What they do is they open the thorax, and then they make a little ligature around the left descending artery. Now we can usually do it by a catheter procedure where we don't have to open up the thorax, but they do it this way. But they say that none of their animals died due to this procedure except one animal, and that was due to arrhythmias 1 hour after the procedure. So I think that they perform a procedure where the dogs survive.
Yeah. Can I ask a question, Lisa?
Yes, please do.
When you ligate an artery, you also ligate the neurons that are running parallel to that artery.
Yeah.
So in that way, in that sense, the balloon occlusion is much more physiological because you don't interfere with the neurons that are innervating the heart.
That's a good point. Because most studies, it seems also that the neurons most affected the quickest after myocardial infarction is in this perivasculature. So this is completely a very good point. They write in their limitations that yes, we did this only in we didn't do the balloon. The balloon. Okay. And that's just what they say, but they don't give a reason for why they did this.
And they didn't discuss the consequences for their interfering with the stellate ganglion.
Yeah. No.
Okay.
No. I like to hear your opinion about it as well, because their discussion is very much focused on this technique and more than actually the pathophysiological mechanisms. They want to see feasible.
I must say that we've done pigs with myocardial infarction, and these pigs have a much more stable arterial system compared to dogs that are very different between individuals. I mean, and we had a problem to get reproducible results. So I'm surprised to see the low numbers of animals that are involved. And I wonder whether the variability between animals is not too high to allow any conclusion. I see that Veronique has joined. She's been working on myocardial infarction in pigs as well. So, yeah, I think this is a concern, the low number of animals.
Yes, and in what we can look at the results, but this very low number and still all the p-values are significant. So that's
Also, please. I also thought on my side that, for example, that using dogs as an infarction model is challenging because they have a significant tributary circulation from the thorax in the myocardium. So if you ligate epicardial, if you occlude epicardial arteries, then but you might not control well the size of your infarction anyway, because
this is true.
Circulation. But I just wanted to confirm with you.
Yeah,
because I never work with dogs.
They have a lot of collateral vessels. I'm not sure how this is in beagles, but this is a problem. We once did experiments with acute ischemia in dogs, tying the LAD, for instance, did not produce any ischemia because the vessel was perfused from the circumflex artery backward.
Okay.
Yeah. But let's continue.
And here, down here below. They have these 3 groups, and they trade in myocardial infarction. At the same time, they give Botox into the left stellate, and then they wait 30 days. Okay? And then they do some analysis. We'll go through that. And here you see this is their ultrasonic image, where they have encircled where they find the left stellate ganglion. Yeah, this is just to show. This is from the supplementary material where they show that there are two deaths in one group and 1 death in another. So they include some more animals. 3 animals were deceased within 1 hour after the myocardial infarction induction. So so that there was a lot of collateral diffusion. Perhaps they wouldn't see that so many arrhythmias. Perhaps, yeah. Okay. Then they write a bit about their statistics. It is very conventional, but they say that they use a student t-test and a one-way ANOVA, and then they accept a p-value of 0.05. When I look at the results, I think there are more p-values for each figure. So I would think that it would be nice if they have said that they did some multiple testing or whatever, because I cannot understand how they can get so many p-values out in these tests. So this is the first result slide, the result figure. And this is just to show that they believe that they demonstrate that there's an effect of the Botox into the left stellate ganglion. So here you look at a protein called SNAP25, and they look at how many cells on histology that are marked. How many cells are marked with this protein? And it's a protein that decreases when we have when we have a neural block. Okay, and this is what they want with the Botox. They want to have a neural block, and they demonstrate that with the control group, the myocardial infarction group, and the myocardial infarction group that had Botox, they have less of this protein. Yeah. So they have a neural blockade in the left stellate ganglion 30 days after. Then they use another protein called tunnel, which is a marker of cell apoptosis. And they want to make sure that when they inject either saline or this toxin, that they don't have an effect on the whole ganglion, that there is not a lot of apoptosis. I would say that cell apoptosis is not the same as necrosis. I don't know. I'm not a histological expert, but this is 30 days later. So I would imagine that the apoptosis would have been stopped by then. either gone back or have turned into cell death.
If it's just a matter of, because as far as I read, the effect of botulinum is to tag this NAP25 for the proteasome. So I don't see any reason except due to the overdosage of this toxin to induce such a necrosis or such an apoptosis that would cause a significant reduction of cell number. Maybe this, for sure, after 30 days, apoptosis is it's terminated. So whatever needed to regrow has regrown, and whatever needed to be substituted has been substituted. So, okay, it's acceptable. Sure. I would not use apoptosis to look at that. But
okay. Oh, that's a good comment. Yeah. Then we move on to their next figure. And this is where they have looked at the left stellate ganglion function after these 30 days. And then what they do is that the animal comes back after 30 days, and then they do a left thoracoscopy, open up only on the left side of the thorax, and then they can find the left stellate ganglion and then stimulate it. And they do this in vivo, where the animal is still alive under anesthesia, but to look at the blood pressure changes while they stimulate the ganglion. And this is what you see over here in the first part of the figure, is that you have the ECG, and they start stimulating, and they see that the blood pressure is rising. So the blood pressure, the amount of blood pressure increase is a marker of how is the sympathetic activity in this stellate ganglion. And then you can see these figures here. They stimulate at 6 different voltages. And in every stimulation, it seems that the myocardial infarction group, without any toxin or without any Botox, only with saline injection, they have a higher response in the blood pressure when they're stimulated in the ganglia. And so more indicative of more sympathetic activity. And when they, in the group that had the toxin, that had the Botox, then there's no, then we don't see such a high increase. And it seems actually it can get really low, much lower than the control group. This is not tested. They haven't tested, of course, control versus the myocardial infarction group with Botox. But it just makes me think that perhaps this is good, that if we can prevent the arrhythmias, but if the patient goes into, if we look at the perspective, if the patient goes into having hypotension due to such an Botox injection, that may not be very comfortable. Or postural hypotension when you get up and you don't have enough blood pressure rise when moving around. Yeah.
Of course, you can't discriminate between stellectomy versus a functional effect of Botox. I think that's the main problem that they want to address with the apoptosis measurement. Because you could think that you destroy the stellate when you inject something.
Yes, but then shouldn't they just have looked at metahistological slice and see how much necrosis was there, how many nerves still viable?
Number of nuclei, yes.
Yeah, so they're counting that. Like Okay, but they see that there's an attenuated activity in the left stellate ganglion when they have given Botox. That's what they can do.
Yeah.
A functional.
Lisa.
Yeah.
Do they also say something about heart rate changes?
No. Nothing supplementary, nothing in the figures.
Because that might also influence your heart blood pressure, right?
Yeah. So if that's not corrected, of course, it is not the same heart rate. Yeah, that's true. If they had a much higher heart rate in the Botox group, then they would equal out if you calculated something. That's a good point. No, they haven't. This part of the figure, the last part, is just to show some representative activation or recordings of this neural activity. And then they quantify that there's a higher frequency of this neural activity in the group that had a myocardial infarction and a high amplitude as well. And then it goes down to become, actually less frequent, I would say, just by looking at the representative recording than the control group.
And where was this measured?
This was just at the left stellate ganglia. So I think
So distal to the, closer to the heart, I suppose, because otherwise you see.
Otherwise you would think what, sorry?
Well, if the efferent neural activity is lower, that cannot be the result of the Botox. I mean, from the brain to the stellate, that should be the same.
Yeah, that should be the same.
Yeah. You expect only difference after the stellate ganglion.
Yeah.
From the stellate ganglion to the heart. But I know that it is very difficult to measure because you have to identify the neurons, which are very thin at that point. So I'm not sure what this tells you. If it means that the neural activity going from the brain to the stellate ganglion is lower, then it cannot be the effect of the Botox.
No. I think this is a very good point. So this activity in the, I'm thinking, no, they did, they didn't.
It doesn't really say. It says a pair of tungsten-coated microrectors was hooked to the LSG, to the left stellate ganglion. Nothing else. I suppose that, I don't know how big it is, the electrode compared to, but I guess you are seeing a summation of the two. But this is weird. It's difficult to say from the methods. There's nothing written.
But would you expect that there's a lot different from the brain? Of course, if this is randomized and their only intervention is the myocardial infarction and the Botox.
Yeah.
Would we expect that? Yeah.
Yeah, but this is measured during left stellate stimulation.
No,
it's during they also do a drug injection, right, to see the blood response, the pressure response, or not?
No, they don't do that.
No, okay.
No, but they could, just like you would test.
Yeah, because I'm just thinking there's always this feedback mechanism through the brain.
Yeah.
And if you have a higher change in blood pressure, that will also lead to less sympathetic activity. So if during in the ischemia group you have higher blood pressures, then it's indirectly might also lead to less sympathetic activity from the brain to the stellate.
Yeah.
And then we do not know if this is related to heart rate because this is not stated.
Yeah. So then I would have liked to see also what happens after a denervation to the brain.
Yeah. Which they could have done because this is terminal. This is for explanting the heart. Okay. So then they look at heart rate variability. Heart rate variability is what we use as a non-invasive marker of the autonomic nervous system activity. That means that they record 5 minutes of ECG and look at the variation in the RR intervals on the ECG. And then they do some frequency analysis. And we usually talk about that the high frequency is a marker of the parasympathetic autonomic nervous system, right? And then we have more of a mixed, please correct me, those of you who have worked with this more than me, but then the lower frequency is more of a mix of both of them. Is that right?
Yeah.
Yeah.
It depends on the scale, but basically, yes.
Yeah. Okay. Yeah.
In stress, there is a lower variability of heart rate. It's more stable.
When what, sorry?
In stress conditions,
Yeah.
stress conditions.
Yeah. Yeah.
But you see that Botox injection has an effect. It normalizes the heart rate variability, but we are injecting in the left stellate, and we know that the left stellate connects to the left ventricle and thereby increases heart rate pressure, I would say, whereas the right stellate has effect on the sinus node. So the effect that you're measuring are probably indirectly caused by the pressure increase or decrease.
But do the stellates not communicate through interneurons? Because the stellate ganglion are not just preganglion, synapse, and then postganglion. I was thinking that they could communicate.
Yes, they do.
But
we know that if you stimulate the left stellate, you get the pressure increase without heart rate increase. If you stimulate the right stellate, you get a heart rate increase without a pressure increase.
Yeah. So that makes these results a bit weird, actually.
Yes, it's difficult to interpret.
Yeah. Because they stated as that this is, look, we see that the autonomic nervous system is, the sympathetic part is downregulated.
Yeah.
Yeah. And then this is also then the D in this figure 3 is that you have this noradrenaline or epinephrine. Yeah, the noradrenaline. So there's also an increase there. Yeah. Okay. Then they go on to look at. Then we go on to look at the functional electrophysiology. And what they do now, they have opened up during the same experiment, they open up more a bit of the thorax and they get access to the ventricles, and then they place 4 electrodes near on the left ventricle, at these 4 different sides, one on the right ventricle apex and these 4 on the left. And then they go on to stimulate the heart. And they first to determine the refractoriness and then the inducibility of ventricular arrhythmia. And they use this S1S2 protocol that perhaps you are familiar with, where you give these pacing stimulus with a fixed interval for about 8 stimuli, and then you give a premature a stimulus in the end to determine the refractoriness. And they have this, I don't know if anyone worked with you worked with dogs, but yeah, I thought it was quite low, their S1 interval of 330, but they do it all in the same. So that, at least that's good. And then they see that the refractoriness or the refractory period is shorter at these ventricular sites in the myocardial infarction group, and then it is prolonged, what seems like to be normalized in the group that had Botox. So there is this functional, we can say, remodeling of the refractoriness after Botox injection. And it's what is interesting is that it seems to be uniform, or what is at all the sites. So there's no heterogeneity here shown. They don't show the result from the right apex, but I think that the right apex, they just use this electrode to stimulate to record their ventricular fibrillation threshold, which is where they just stimulate to see when they get VF and at what voltage.
It's a pity, really, because you would expect that distal to the infarcted tissue, you would have denervation of
Yeah.
the tissue without infarction.
Yes, exactly. Yeah. That's a very good point. And this is where these areas get more sensitive, right, in the aftermath of the infarction.
Yeah. Yeah, it adds a bit, Veronique, to our experiments, because we know that in pigs, at least, I'm not sure whether it's true in dogs, that the anterior part of the left ventricle, which we are measuring in now, is not innervated by the left stellate, but by the right stellate.
Yeah.
So I wouldn't have expected any change.
No, I was about to make a similar comment, indeed, because it's only anterior, right, that they measure.
Yeah.
Right and left. So in that aspect, I won't expect changes in repolarization. Other than maybe the infarcted, but it's 30 days, right?
Yeah.
1 month. That's not long enough to expect some prolongation of your repolarization, as you see in heart failure.
Yeah.
Because you want the to be nerve sprouting. You think is that the idea that you need more?
No, well, I'm just thinking about in heart failure patients, you see quite often prolongation of your repolarization. But that's longer after your infarct. So
they go into failure. No, I get it. Yeah. Okay. Yeah.
Also, I don't know how big it was their thoracotomy, but I usually don't trust very well the repeatability of positioning of catheters manually. So this might be like really due to it's anterior, but it's more lateral.
Yeah.
So it's not size anatomy.
Peter, what would you have done? Or could?
On top of my feet, I don't know. I would probably not have been more precise.
Yeah,
for sure. You need to somehow suture the catheters in order to be sure in your position.
Yeah.
So that's a good idea. Yeah.
Manually, it's a problem. Like even if you arrive, like I did an experiment when I arrived with a controlled arm. So at least the catheter was not moving, but anyway, the heart is moving, is not in the right position. These animals, like, it's facing upwards, so it can slip. It's challenging to keep the position. You still have quite a good signal, but I mean, at least I don't know the shape of the heart of the dogs. But the more, for sheep, for pig, for me, the more you go to the apex, the more slippage you have.
Yeah.
Here, I trust it. Here, a little bit no, in the middle part on the apex. So there might just be like, I'm absolutely not an expert of innervated areas of the heart, but I would give the benefit of the doubt of the human factor if this is positioned manually.
Yeah.
Not to overinterpret the results. It's complicated.
Yeah, exactly. Also the peri-infarct area. How can
exactly. Yes.
How can you be sure that you're not in the infected area?
Yes, exactly.
Yeah.
And they misspell it as well.
Yeah. Per-infarct.
Per-infarct. Well,
this is the editorial office. I'm joking.
It is almost too good to be true, all these figures, I must say.
Yes, that's what when you see the points, because there are so few, of course, and it just, it looks very, good to be true, perhaps. But they actually have one p-value that is different from what I think they expected. So I think we'll get to that.
Okay.
This is their last result that they show. They take out the heart And then they look at the histology and look at the myocardial infarction, the size in the dogs. These are these sausage slices, we call it, at least in Danish, where we go through the ventricles, the axis view, and the myocardial infarction with the Botox. So, and there they quantified on imaging on histology and see that there is a downregulation of the infarct size. And then they do some
Is
imaging.
this the unexpected part of it?
No, actually, this is the unexpected part. This is when you see on here. They have a p-value. I'll get to it. They will go through. They will do echocardiography.
Yeah.
Thing also to look at if there's any heart failure or whatever. And then they see that having modulated the autonomic nervous system, you have a normalization of the ventricular volumes and also the ejection fraction. So less failure. But then they use this value. I don't know if you know it. And E over these are the inflow from mitral inflow at two different time points in the cardiac circle. At the moment when the mitral valves open or when the atrial when they open and we have the diastole, the ventricular diastole, and then later on the A wave when you have the atrial contraction.
Yeah.
The marker more of the diastolic dysfunction. And actually it seems that there is an improvement compared to control in this infarct Botox model. So
I thought an increased E over A ratio was associated with HFpEF. So then in that case, Botox would cause HFpEF.
Oh, I thought it was when it decreased. Let's see, we have the ratio, but I'm sure you're more familiar with HFpEF than me.
Oh, I'm not sure now, but
we have the atrial contraction. We want the atrial contraction to.
Well, you would have more diastolic inflow rather than atrial contraction.
Yeah, when it's higher.
Changes. Yeah, when it's this, the ratio is more elevated. So either you have.
That's good, right?
You have an atrial dysfunction, or you have
True.
more.
Yeah.
You have more lusitropy.
Yeah.
In the ventricle, but you can have an atrial dysfunction.
Yes, I didn't think of that. This is only the ratio. This is good, of course. Yeah. But yeah, I think this was an unexpected for them.
But if you look in panel B, you would expect the infarct size to be the same, wouldn't you? Why wouldn't it be smaller?
Yeah, this is funny because they don't really discuss it in the discussion. They mostly discuss this Botox injection and how the methods apply to that. Yeah,
Yes,
I think they want to say that the autonomic nervous system also modulates the structure after myocardial infarction, and yeah, you have less
probably pressure-induced remodeling.
Yeah.
If you have more pressure on an insulted myocardium, your fibroblast will, your cardiomyocyte will die faster.
Yeah, but may I ask to this, because for me panel B was also a bit striking. When was the first injection of Botox after the induction of infarction?
Yeah, that's a good question.
If it was after or just before?
No, they made the ligation, right?
Yeah.
They induced in myocardial infarction in both groups, same way. And then when was the first time in the MI plus BTA group when they administered the Botox?
At the same day. And
at the same day?
The same time they did it. They was doing this.
Okay.
They only saw the animal on that day and then 30 days later.
Okay.
Yeah.
Yeah, but now you don't know whether the effects of Botox are mediated by the smaller infarct or by the interruption of the neurocommunication.
Mm-hmm.
So I think you should select the animals with the same infarct size and compare them.
Yeah.
Or do the opposite, do the infarction and then the Botox injection and see if it makes some difference.
Exactly.
Yeah.
No, how do you mean that? How do you mean that, Guido?
It's just because this is just correlation. But there is no. There is a direction between the two interventions. So there is BTA, there is Botox and myocardial infarction, but we don't know if it's which caused which.
Yeah.
So
Yeah.
like if you added the group with like I read here in the protocol, first they did the injection of Botox and then they ligated. If you ligated and then you do the injection of Botox, then you have the group that gives you the sense of the arrow. So
yeah,
it's either like, yes, exactly, like it's either the Botox that caused the less myocardial infarction or vice versa. It's just like it's correlative observation here. Like we cannot say anything on the causality. That's all.
Lisa, I'm completely confused now because they create myocardial infarction by ligation. So they open the thorax.
Yeah.
And then they do Botox injection guided by echo. But if the thorax is open, you can inject Botox directly into the stellates because you can see them.
Yeah.
I
think they want to, but they want to have a model that you can do when you're develop a procedure that you can do when your patient comes into the clinic with a myocardial infarction. I think that's the thing. They wanted to develop that without the open thorax. But true, they could have done that.
Yeah. Okay.
Yeah.
So what would you say is the conclusion of this paper?
I will let them talk. They say that the ultrasound guided injection of Botox into the left stellate ganglion can suppress cardiac sympathetic hyperactivity and then prevent this cardiac remodeling after chronic myocardial infarction. So they give the reason to Botox for this less structural remodeling as well. And then they discuss a bit of their limitations, that they only looked at 30 days and and they're, I think, small numbers and it's only a dog and so forth. Nothing really
critical.
Nothing really critical, I would say. And also this is their fourth limitation is this catheter-based, they don't use a catheter-based myocardial infarction model. And then, I asked as the last question if we should use this Botox injection after myocardial infarction.
No.
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 I wouldn't. You lose all your capacity to respond to stress.
Yeah.
Everybody likes stress.
Yeah, indeed. You need it. But do they also say something about the location of your myocardial infarction in combination with which side of the stellates you inject Botox in? Because we know from our studies that it depends on the location of the myocardial infarction whether one of both is arrhythmogenic. The left stellate in combination with a LAD occlusion is more arrhythmogenic, but in CX occlusions, you have more arrhythmogenicity because of right stellate activity.
They don't discuss it and they don't show any evidence for it, which is true if they could correlate on what side. And they don't discuss either there are collaterals. This could also be
a major thing.
Yeah. A confounder in this infarct size. No. Yeah, and they could do more harm, you see. And also they lose 3 animals acutely. And they say this was 1 hour after myocardial infarction. We don't know if it was actually also after their Botox injection in 2 of these animals. Perhaps this was actually, we had a hyperacute pro-arrhythmic effect of the Botox.
Yeah.
And they died. Their group is so small that 2 animals out of 6, this is quite a group if it's pro-arrhythmic. And then we had the others, and that's where they show an anti-arrhythmic effect.
More interesting, and I have to ask you because this is out of my competence. Is it possible to hyperpolarize the stellate ganglion on the afferent side to prevent this increased release of acetylcholine and this irregular innervation? Like if we could put, like for example, for the vagal nerve, we can put something on the ear. And it's, well, not here. And we can inhibit it somehow. Is it possible to do it as well for the left stellate ganglion? To inhibit it? Like, so a patient comes with an infarction, we put you a nice stent and we inhibit your, temporarily your left stellate ganglion so that your infarction does not grow as much as it should, as you have ischemia reperfusion injury and blah, 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 blah.
Now we give beta blockers.
Yeah, exactly.
Oh, okay. Perfect. Sounds about right.
Quite well.
Yes, it works.
But of course, the efferent or the afferent, I think anatomy is against you to
Right.
find these efferent sites. But I agree, yeah. In comparison with the vagal stimulation. In the heart failure, Veronique, you know more about this, but it seems that there is a depletion of noradrenaline in the heart.
I see.
There's more adrenaline out in the plasma circulating, but in the heart itself, there's less adrenaline, or the neurotransmitter from the sympathetic nervous system. I don't know if this, I'm just saying that I don't know if you want to deplete your sympathetic system in your heart by stimulating, say, overstimulating, because that will perhaps mimic heart failure.
Yeah, exactly. But it depends on the context. If it's beneficial temporarily, of course.
Yeah.
Yeah. Okay.
Oh.
Well, maybe one more comment. See you at the University of Copenhagen. Yes.
Okay.
We'll
No,
come.
sorry, Ruben, you wanted to make one comment.
Yes. They don't comment on the controversy that has been there between left and right stellate ganglion modification. There's a very old controversy, and Peter Schwartz, who is the father of left stellectomy almost, says that left stellectomy is beneficial and right stellectomy is bad. So like a yin-yang difference. And therefore he advocates only to do left stellectomy in these patients. We are not of the same opinion. We think that you have to do both sides and that it depends on the side of the ischemia or the infarction, whether or not stellectomy is beneficial or not. But they don't comment on that, and they blindly assume that left stellectomy is the best thing to do. But I certainly would try in their place to do it at the right side as well. And I think then that the advantage will be more balanced if you do both sides.
Yeah, both at the same time.
Yeah.
And then measure your heart rate.
Yeah, also, yeah. Okay. See you next time in Copenhagen then.
Yeah, very welcome. And for the Greek people, can I just say that I'll be there in the middle of your holiday. So let's see who are there. But on the 15th of February, I'll be making a little talk down at your amphitheater.
Good.
Lovely.
So,
About atrial fibrillation, I suspect.
and the pulmonary veins. This is
Okay.
philosophical.
My turf. Perfect. Another
Thank you
pulmonary
for
veins.
your presentation and see you there.
Yes. Okay, thank you, Lisa. That was a wonderful presentation,
Yeah, thank
interesting
you.
paper. Shows us that we can discuss better even if the paper is not that strong. gives rise to nice discussions. Okay, thank you all. The next Journal Club will be in February. I'm not sure who we will be presenting. at
It's
that time.
Veronique.
It's
Yes.
Veronique. Good.
Yeah.
Do you know a topic already, Veronique?
No, but I guess it will be something with about CRT.
Okay, good. So see you then, and see you
Yeah.
later.